Good morning, everybody, and a really warm welcome to today's webinar. What is it with hormones and MS? And it's wonderful to see so many people attending from across Australia. Today is a collaboration for Women's Health Week with Jean Hales and MSA. It's the first time we've been involved with the Women's Health Week, so we're really excited to be a part of that. Our presenter today is Professor Jeannette Lechner Scott. We're very fortunate to have Jeannette presenting today, and I'll introduce Jeannette a bit more formally in a moment. I'm your facilitator, Nicola Graham, and I'm part of the education team here at MSL. So we like to start our programs with an acknowledgement. So I'd like to acknowledge and pay respect to the traditional custodians, past and present, on whose lands we meet today. And we acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and respect the cultural authority of the elders in each community. So I'd like to more formally now introduce you to Professor Jeannette Lechner Scott, who's our presenter today. So Jeannette is Senior Staff Specialist, Department of Neurology at the John Hunter Hospital in Newcastle and Conjoint Professor at the University of Newcastle. Jeannette trained in neurology in Germany and in Switzerland and completed a PhD regarding pain. Since arriving in Newcastle, Jeannette's been very busy. She started a multidisciplinary specialised clinic for MS patients, and that clinic is now one of the largest in Australia. She's the founding member of the ANZ Gene Consortium, which has published several leading reports on the genetics of MS. She's pioneered the field of epigenetics in MS, and other research interests are cognitive function and its impact on daily life for people with MS. She's currently the Australian representative for MS Australia on the International Medical and Scientific Board. So a very warm welcome to you, Jeannette.
Thank you for this warm welcome, and thank you for inviting me yet again to present. I'm just making that a little bit bigger. So as you said, I'm running the MS clinic in Newcastle, and we're covering a fairly large area up to the Gold Coast is the next MS clinic, and down to Sydney is the other one, and out west there's a lot of patients who usually travel long distance to see me, but now just phone in or video telehealth me, which I find not quite as good as the routine. And I'm looking forward to getting back to the normal routine and seeing patients and having them in my room and having an eye-to-eye chat with my patients. So we're talking about hormones and women. And you can see that here from all the advertisement that is going out, all the companies are targeting women. And that has a reason. Oops. What is the ratio between female to male in MS? Do you know? Can we just go and vote for that? It should be fairly easy. Is it 1 to 1, 2 to 1, 3 to 1, 5 to 1, or 10 to 1?
That's great, Jeannette. So I've just launched that poll for everybody to try and have an answer. Just to let you know, it's totally anonymous, so you can completely guess, and we'll never know what who's answered what. So I can see that over 80% of people have voted already. So you've obviously got the hang of doing this. Well done, everyone. Wonderful. And I'm just going to wait a few more moments.
Because then I can see that you're all still awake, because I can't see you and see if you follow or you're going off and doing emails, but these questions will be in between to wake you up.
That's great. And yep, there over 99% of people are still awake, Jeannette, so that's fantastic. And I'm just going to close that poll and we'll share the results there with everybody. So Jeannette, I don't know whether you can see those results and want to talk through them.
Great. Wonderful. So all well-informed people, that's very good. So most people would agree that MS is on the rise. There is increasing prevalence and incidence in most countries reported. I'm just trying to get myself out of the picture. Do you see my picture in front there? So some, especially elderly British neurologists, might argue this is only these increasing incidence because there's more neurologists around and more MRI scanners, and therefore we diagnose the disease more frequently. We certainly diagnose the disease now with the new diagnostic criteria earlier, but this is because we now have treatment. There's also a reason to diagnose it earlier, and there's a reason to diagnose it to prevent disability longer term. But something that definitely has not been debated is that we do have more females diagnosed, and especially we've done a survey in Australia in the 2011 and compared it over the last 60 years. We can compare it, and 60 years ago the female-male ratio in Newcastle was 1:1, and now it is 3:1, and this is where most people, 2.6 to 3:1 is where most countries have their female-male ratio. This is not the case in primary progressive MS. And there was a large MS-based study that looked at female-male ratio with regards to relapses. I'm just trying to get a pointer. Can you see my arrow here? So primary progressives don't usually have relapses, and there the ratio between male and female is 1:1. But relapses even in 8 relapses over 10 years, the really high number in active disease is far more common in 3.5:1 in female than in male. That is
and
not.
Jeannette, yes, we can see your pointer. We can see your pointer.
It appears every now and again. This is not all bad news. We know relapses do drive progression in the disease and do drive disability. But if you score people reaching an EDSS of 5 over decades, it is actually male that reach it faster than female. So here again, there is a study showing that in primary progressive, male and female ratio is the same, but female to male, far more common in relapsing, remitting, and secondary progressive than male. So more relapses in females, but more progression in males, and they have a poorer prognosis overall. So next question. What does pregnancy do to my risk of developing MS? Nothing. Reduces the risk of developing MS, increases the risk of developing MS, delays the risk of developing MS, and prevents the development of MS. So this is a bit more difficult than the last question, I think.
So you can select all that apply, or you think apply from the following, and I can see people are having to think a little bit more about this one, Jeannette. So only half, just over half of the people have voted now, which is great. As I say, you can have a guess, guys. Go for it. That would be fantastic. So most people have now voted, which is terrific. So I'm just going to close that poll now. Thanks, guys, and just share the results.
Excellent. Really well-informed people on the call, because this is research that has only just been published, or So this is one that study that is derived from the OSLong study that has been around for a bit longer, so in 2012. I don't know if you're aware of that. These were in 4 different centres in Australia collected clinical isolated syndromes, so just at the beginning of the disease, and compared to 2 or 3 healthy controls in the same postcode. And then we looked at all sorts of environmental factors. One of this environmental factor to compare MS and healthy control was pregnancy. Yeah, so 2 healthy controls versus 1 first demyelinating event. And out of 282 cases, there were 216 females and 422 healthy control females. And surprisingly, so the odds ratio for that reduced with the number of births. And significantly, if you had 5 births, and I'm sure all these pregnancies came from Newcastle because all the other centres wouldn't have that many kids, I would think. But this has now been confirmed also from a larger study from 4 different centres in the world with over 2,000 pregnancies and patients that, so this was comparing the age of onset of MS with people that had a pregnancy and people that had no pregnancy. So gravida is someone with babies and nulli gravida is never having had a baby. And you can clearly see that not having had babies brings your incidence of having the first demyelinating event forward. So earlier diagnosis of MS if you haven't had a baby. Then we looked at if the number of pregnancies has an effect, and that does not seem to be the case. Yeah, so it didn't matter if it was 1 pregnancy or 3 or more, the risk reduction didn't increase. So I think every neurologist, every MS specialist should sit down with a woman that has just been diagnosed, or even if they have been already diagnosed, and have a discussion about family planning. There's a lot of my colleagues, especially the male, who palm that off to the MS nurse if they have one. But it is something that family planning should be discussed with your neurologist together with the obstetrician. And there's a lot of obstetricians that I'm in constant contact, in particularly if one of my patients chooses to go for IVF. And I'll get to that in a minute. So there's a lot of questions that women with MS asking themselves. When should I become pregnant? What is the optimal time? Should I wait until my disease is controlled? Should I start early, delay my treatment? What if I have babies? Is that going to do to my to my disease, or what does my treatment do to my baby? So lots of questions that need to be answered. So the first question, when should I become pregnant? As soon as possible? When my disease is stable? When I have to give up work? I mean, work is an important factor in the family planning. The later, the better. Not at all. My children might inherit my genes. It's also
Wonderful.
not so easy to answer.
So we've got just select one here, but I can see that most people have already voted, Jeannette. So I'm just going to give people a couple more moments to cast their vote. Certainly everybody's still very awake, Jeannette, so that's fantastic. Okay, we've got just about 80% of people have voted. So if you want to quickly put in your your vote now, and I'm just going to close this poll and share the results with everybody. Here we go.
Excellent. Wonderful. It's good to see that people read the up-to-date literature. Excellent. Wonderful. So it isn't just to the point E, which MS is not an inherited disease. So it's not one gene that you pass on to your offspring and 50% chance of getting the disease. But we now know that there is over 200 genes that predispose you for MS. And if in general the risk of developing MS is 1 in 1,000, your child will have 7 in 1,000. So there is an increased risk in your children, but that doesn't necessarily mean that they have to develop the disease. So 993 out of 1,000 will not develop it.
Jeannette, I've just got a question here from Jane.
Yeah.
Is that increased risk the same if you're the mum or the dad? Does that come from either parent?
That is a very good question. There's older studies that say that having a father who has MS is giving you a higher risk, but I'm not sure if that still is completely true, and that hasn't really been looked at in more detail recently, and I think there's a lot more research done now. But if the inheritance of the father or mother side is more prominent, I would still put a big question mark.
Okay, thank you.
So it is all very well to plan a pregnancy, but we should be aware that the majority of babies and pregnancies just happen. Maybe when you are a person with a chronic disease, you think about it a bit more and are more careful to, when you are on treatment, to use precaution. But 51% of Australian women have at least one unplanned pregnancy. The other thing that is important to note, that the fertility rate is going down since the 1950s, and the age of pregnancy is going up, which is probably in combination, therefore, because we're delaying our pregnancies more and more, the fertility rate might go down. I think that is one of the possible hypothesis, delaying pregnancies to the late 30s while the incidence of MS is going up. So in 1961, there was the average number of kids was 3.5. In 2008, that went down to 2. In 2015, it's 1.8, and less so in Victoria than in Northern Territory. In the same time, the IVF rate is going up, and currently 4% of all babies are produced with the help of artificial reproductive technology. And that is because we delay our pregnancy. Why would a woman with MS have difficulties with fertility? Well, sexual dysfunction is quite common in 30 to 70%. It's not only reduced libido, but also difficulties reaching an orgasm, sensory disturbance, bladder and bowel problems will contribute to not having as much sexual intercourse as normal. And then there are hormonal abnormalities. So if we compare healthy controls and women with MS, there's a higher FSH noted, a lower anti-Müllerian hormone, which is a hormone that's associated with ovarian reserve, and a higher prolactin. And then there is other comorbidities that certainly don't help fertility. Endometriosis is more common in women with MS, and it's one of the major factors of infertility. And depression. So it is actually surprising that you ever looked into fertility in MS, and that's a study from Roux from France from 2015, that the fecundity in MS women, and it's a small cohort, and I'm not sure if that is really true in the whole in a larger population. So he only looked at 115, but compared it to the national statistics for all women, and couldn't really find a difference, a statistically significant difference in the number of children per woman. But if you can see, although in the younger age, no, you can't see it. Whoops. I'm not getting my error. So in the age group of 20 to 29, there doesn't seem to be a difference, but then later on, there does. There is actually more of the general population had a higher number of children. Why is this so? We always have thought of pregnancy like a transplant. You have a foreign organ in your body. It's not that simple. So there is a complex immune system changes that happen when you fall pregnant. It is very interesting to see that it's predominantly innate system that is changing. The uterine NK numbers are increasing to help implantation of the egg. So that's an intrauterine NK cells is something that can be measured in IVF to see if you have difficulties conceiving. Unfortunately, it doesn't correlate straight with the peripheral blood natural killer cells. But it's an interesting concept because we know that increasing number of natural killer cells, which is an effect that some of our disease-modifying therapies have, can cause, is associated with a more stable disease. And therefore, pregnancy is usually considered to be a better state for MS. This is not true for all autoimmune disease. Patients with lupus have actually more disease during pregnancy, and also neuromyelitis optica, they have more relapses during pregnancy. So it's not all autoimmune disease is ameliorated with pregnancy, but definitely that has been described with multiple sclerosis and also with rheumatoid arthritis. So you do need more immune cells in the placenta for the implantation and for the safe implantation, because you do not want bacteria or viruses getting into your womb at the same time as your baby is implanting and growing. So we usually see an increase in GM-CSF and an increase in neutrophils in women that fall pregnant. And you do see an increase in particular regulatory T cells. So you have a change from Th1 to Th2, and this is something that we can see is very positive for MS. And then in the third, just before you have the baby, then your immune system is stimulated again. You make sure that you're prepared for the passage out of the womb, and therefore the postpartum relapses are going up and the activity goes up again. But we'll get to that in a moment. So you basically reject as an organ your baby at the end of the pregnancy. So this, if you, so there was already the PRIM study in the 1990s, but this was also confirmed in 2014 with the MS-based data. So if this is the, if that is the annualized relapse rate at the beginning, I really would like, where is my error, not coming. In the first trimester, it slowly, the annualized relapse rate goes down. In the third trimester is the lowest relapse rate, and then it rebounds to the pre-pregnancy time again, postpartum. This is something that we now have looked again because it might change, and it depends on what you're treated with. So this graph shows control pregnancies and patients who actually have been on natalizumab and stopped their natalizumab when they fell pregnant. And you can see that there is a rebound phenomenon happening in patients who were treated with natalizumab, and they now have a quite high rate of relapses during pregnancy. And this happens also in fingolimod, and therefore planning a pregnancy and stopping your current disease-modifying therapy might not be the best choice for everybody. So nowadays, 22% still have relapses during pregnancy, yeah, and 14% after. What are we doing about MRI? You actually can do MRIs during pregnancies. We don't usually give gadolinium, but if there is disease activity, that might be an option. Steroids are safe in the later pregnancy, but they're not that safe early, so preventing a relapse would be better. I have had only one patient of mine who had a baby with a malformation. She was someone who really wanted to plan her pregnancy early on and didn't want to be on any treatment, and she was only on Copaxone and glatiramer acetate, stopped it, and did have a relapse during pregnancy, and then was treated with high-dose steroids. So early on. So there is a risk with steroids as well. In the later pregnancy, it can be given safely. And there was a study looking at immunoglobulin during pregnancy in patients with high activity status. Unfortunately, this study did not show that it actually changed anything in the pregnancy. So you all know that treatments like fingolimod or natalizumab are treatments that affect the lymphocyte trafficking. So fingolimod, as you all know, stops lymphocytes of getting out of the lymph nodes, and natalizumab stops lymphocytes of getting into the brain. So the lymphocyte proliferation happens like it did without these treatments, or what you do basically is putting the brakes on. And when you stop the treatment because you want to become pregnant or for any other reason, then we do see rebound. So in that one study from 2018, 10% had after stopping fingolimod, had a severe exacerbation. And natalizumab, there is, you know, even after switching to another effective treatment, 17% reactivation. And we know exactly that we should now, we're very wary that somewhere between 6 to 8 weeks to change to a different treatment, or to keep it going in the pregnancy so that then the third trimester, when your pregnancy is protective, no rebound will happen. So this is one study showing of all the relapses that occurred after stopping fingolimod for pregnancy planning. But coming to the earlier questions that you all answered so nicely, yes, the best way of preventing postpartum relapses is to have a stable disease prior. And this is yet another MS-based study on 893 pregnancies. The best way of reducing your postpartum relapse is by being on disease-modifying therapies in the 2 years prior to the pregnancy. And this is a study that has also been shown by Fragoso. Being on disease-modifying therapy during reduces your risk of relapses after. And not only that, but also of EDSS progression. So what treatment to choose? So we know about the injectables for a long time. We call them now all low efficacy treatments, but they have one advantage, that we have seen lots of pregnancies with these treatments, and they have not shown to have any effect on fetal abnormalities and pregnancy outcomes. So the standardized ratio is actually beneficial. That is for the glatiramer acetate, for the Uricat reference rate, and this is a large study for beta interferon. It does not seem that neither of these two drugs given before, in the first trimester, or even during the whole pregnancy has an effect on the pregnancy outcome. So this is why this has now been included in both product information, which doesn't mean that the high efficacy treatments are all dangerous and these are good, but it's just that they have a hell of a lot more data to allow them to have it in their product information than the newer drugs. I think maybe more safe than continuing treatment are giving treatment that are more induction therapies like alemtuzumab, cladribine, or ocrelizumab. Ocrelizumab I wouldn't call an induction therapy, but we know that we currently give infusions every 6 months, but we also know that the effect is lasting longer than the 6 months, and there's no rebound described in any of these treatments. So the recommendation is to wait at least 4 months after alemtuzumab. Alemtuzumab, the studies had the highest pregnancy rate of any clinical trial, so they were succeeding in having 200 pregnancies in their trial and no significant negative effect. Cladribine is a difficult one. There is an effect on sperm, but nothing described on ovaries. There is some teratogenicity described in monkeys. They recommend to wait 6 months after treatment. These alemtuzumab and cladribine, if you're not aware, are treatments that you give once a year, usually 2 years consecutively, and then not after, because you reboot the immune system, and hopefully when you're stable you don't require any other treatment anymore. Therefore, having had alemtuzumab or cladribine in the past, we hope does not affect your chances of falling pregnant or pregnancy outcome. But we don't really have that data to be sure about this.
Jeannette, can I just clarify what you mean by an induction therapy, please? And I have got a few questions as well.
Yeah, please do stop me at any time. So induction therapy, as I said, alemtuzumab and cladribine are best given early in the disease so that you reboot your immune system and you have a long-lasting effect. Yeah, rather than treatment like ocrelizumab, natalizumab, fingolimab, you have to keep going all the time.
Great. And Jeannette, if you don't mind, I've got a few questions from the last few slides, if you don't mind me running past these past you. So Alicia's asked, is there any evidence for relapse if you keep taking DMT during pregnancy or part of the pregnancy? I know something like natalizumab can be taken for a period of time during the pregnancy.
Yeah, I'll get to that in a minute. All product information said not to be giving the treatment during pregnancy. So if your doctor is recommending it, to continue taking it, so that is now allowed with interferon and beta interferon and glatiramer acetate if your disease activity requires it, and I think this is the formulation that is included. But all the other treatments do recommend to stop when you have fallen pregnant. We do not have a prospective study looking at what happens if you take it the whole pregnancy, and I don't think we will ever get that because the risk of the fetus might be too high.
So it sounds like quite a nuanced conversation with your neurologist, depending on your disease situation, and it's a more nuanced conversation.
With regards to natalizumab and the timing of that, so I'll get to that in a minute.
And a question from Jennifer: what do you consider as late pregnancy in weeks?
That is also
referring to the cortisone.
The cortisone, yeah, no, that's the third trimester, basically. So we usually even give premature babies or early, steroids to enhance the baby's development of the lung. So in the third trimester or late last 10 weeks, I think it's fairly safe.
Okay, thanks, Jeannette. And then a question relating back to the inherited risk. Janet here is saying her sister, 3 years younger than her, has had MS since 95. She was also diagnosed in 2009. They've got other siblings, but no parent with MS. Is there any increased known risk for her siblings, given 2 in the family have already got MS as well, but no parent with MS?
So there is 3 siblings.
Janet hasn't told me how many siblings there are, but there's more than 2, and 2 of them have already got MS, but no parent with MS. So is there an increased risk to the other siblings?
That's a very good question. If there is 2 siblings having it, I would assume that there is some of the autoimmune genes in the parents. So what we think, so the autoimmune genes, so the genes, the 250 genes that we've described increasing the risk of MS, they all hover in the function of T cell proliferation, B cell proliferation, not so much in the brain function area. There are similar genes to type 1 diabetes, to rheumatoid arthritis, even celiac disease. So maybe your parents don't have MS, but they might have thyroiditis, they might have type 1 diabetes, or some. So if these genes then combined, maybe it's a dose effect. So father has some autoimmune genes, mother has some autoimmune genes. But I would assume that the risk is higher for the siblings as well, just out of statistics. But the individual is always different.
Great, thank you, Jeannette. And I've just got one more question from Kim. Do women with MS have a higher likelihood of prolonged increased cortisol due to chronic stress associated with the disease?
So it's not that simple. So the cortisol levels of a person with MS is not higher than the general population. So there is a recent study, I haven't read all the cortisol studies, and I haven't done a specific literature search on that topic, but my understanding is that your stress response might be slightly different if you have MS. but not that you have an ongoing higher cortisol level.
Great, thank you, Jeannette. And that's all the questions for now.
Okay, so let's get moving on. So monoclonal antibodies is during pregnancy. So large molecules are unlikely to pass through the placenta. It's like the blood-brain barrier. There is a blood-placenta barrier. So especially in the first trimester, monoclonal antibodies like ocrelizumab and natalizumab might not pass to the placenta. But then in the third trimester, and here we're getting to why we're thinking how long we should be giving that, what we do see that babies that are born after ocrelizumab has been given during early pregnancy or too close to the pregnancy date, that they have a reduced immunoglobulins. So their B cell, the baby's B cells are affected, and they can't, the mother hasn't transported any immunoglobulins, and the baby has a delayed B cell reactivity and can't produce immunoglobulins. So the baby or the fetus is then susceptible to infections early on, which can be quite dangerous. So ocrelizumab is not as safe as some people might put it for pregnancy either. So this is the slide telling you on which our recommendations with natalizumab is now based. This was an observational study, and you will never get a randomized controlled pregnancy study because this is not going to go through ethics. So there were, I think it's about 100, it's very small, and I apologize for that. But I think it's almost 100 pregnancies in a multi-center Italian study that were enrolled, some of which stopped natalizumab as soon as they knew that they're pregnant, some stopped it early, and some took it on an average of 260 days. And we can see here that this can, I need to get you out. Oops. Hang on a second. Can I just move this out of the way? I don't know why that pops up all the time. Can't see my own slide otherwise. There we are. Going back. Sorry. So clearly the patients that, so this is the one that stopped the natalizumab, and as you can see, not only did they have higher rate of relapses during the pregnancy, but also postpartum. This is slightly better with the ones that stopped early in the first trimester, but the best were the ones that stopped late. So what we therefore recommend now is about 28 weeks. So the last trimester, when you get the active transport of monoclonal antibodies into the system, you're probably better off stopping. Some recommend to have a 6 weekly intervals because that's a safer option. Because natalizumab is not harmful for the baby. So in their cohort, they said there was no significant difference, but they had, in the patients, in the babies that were exposed to natalizumab, 4 out of 30 pregnancies had some sort of malformation. And especially the ones that where the average exposure was 260 days, did have anemia. This is a side effect. The natalizumab affects the bone marrow production of the fetus. So there are risks involved in continuing natalizumab, and therefore you need to really carefully evaluate how active is your disease. You don't want to have a relapse, but also the risk to the baby. So that is a very, very individual decision, and you need to make that together with your neurologist and possibly also your obstetrician. So, in case you do not fall pregnant, what does artificial reproductive technology, IVF technology, do to my MS?
Okay, so we've launched that poll and inviting people to vote.
How does it affect my MS? Not at all. I can't be on treatment when I see a fertility specialist. Gonadotropin releasing hormone agonists affect my MS, or antagonists affect my MS, and miscarriages affect my MS.
Now, I just want to flag that I think this is a really, really tricky question. So I can see people are quite slow to vote.
Been to an IVF specialist, you probably don't know what gonadotropin releasing hormones do and what the difference is between antagonist and antagonist. It is actually, I find, very confusing that they use both agonist and antagonist in IVF. So the agonist, so usually your gonadotropin releasing hormone is released in a pulsatile fashion, and therefore you can all give an antagonist for 1 day, and then it stops the receptor and stops your LH surge, luteinizing hormone surge, or you give it for a week, that's the agonist, and that stops the LH surge. Both treatments affect your estrogen level. You want to show the results? Have we got any?
Yes.
Oh, everybody
yes,
waiting
for the explanation. 60% of people have been brave enough to vote, which is fantastic. So we'll share those results from the brave 60% who had a go. Well done, you guys.
Good. So again, people have read the literature, so that's really good to know. And that's where that is formed from. But it also shows to me we actually don't know. And I think that's, I'll show you why.
It was a trick question.
So the people that voted for agonists affect my pregnancy, or have read this article. That's a French article, and they actually didn't have that many pregnancies. So that is always something that you need to take into account. If you look here, the numbers, it's not that many pregnancies where that is related from. And they seem, compared to antagonists, the agonists significantly affected the relapse rate. But recently there has been a meta-analysis done by Briley Bover from San Francisco, and she looked at the Boston cohort, and the Boston cohort has the opposite. So I don't know if IVF is affecting relapse rate, the postpartum relapse rate. I think there's only 220, the total of 220 pregnancies or cycles. There's big questions still around if antagonists are just more effective treatments, and this is, I have been told by an IVF specialist now, Australia use more commonly antagonists, not because of the risk of relapses in MS, but because it is a safer drug and a more effective drug to get enough eggs harvested for IVF. There's a big question if it isn't failed cycles that causes relapses during IVF, because the sudden loss of estrogen is like in the postpartum trimester, is increasing MS activity. And there has also been a recent case where a gonadotropin agonist therapy was used for uterine fibroid, and that triggered MS activity. So I think we really need to look at that a bit more carefully. But if we look at what pregnancy does to the long-term outcome, we can see that that was again an MS-based data analysis from 2016, that each pregnancy improved your or decreased your risk of having an EDSS change in 10 years, and that effect was stronger than the effect of beta interferon. After this study was released, I thought I'd prescribe now one pregnancy after the other, but it's not that simple. So,
and it's quite expensive, I think, Jeannette. I've found that children are quite costly.
This is a study from the Barcelona cohort with CIS, and they disagree with Vilja, and saying that pregnancy, once you adjust for everything, does not really have an effect of developing clinical definite MS or McDonald criteria or reaching in the EDSS of 3. Yeah. So if you don't adjust, yes, it does. And if you do, the hazard ratio is not really significantly different. And similar to breastfeeding, so there is some benefit, but if you adjust to all factors, age at CIS, topography, where the lesions are, oligoclonal bands. I mean, they might have adjusted all the variants out and there isn't enough sample size to find anything, because we just submitted a new paper to Lancet, and I can't show you the results of that, but it clearly did say in the cohort of over 2,000 pregnancies that breastfeeding the first 3 months, which we assume is purely, does have a benefit on your EDSS outcome later on. And that is confirming what Portaccio has found in a smaller study, that relapses in the year after delivery is the most significant factor to predict your disability later on. So preventing relapses postpartum should be our aim when we plan pregnancy. And this is the reason why we take into account that natalizumab, for example, can be potentially dangerous for the baby, or ocrelizumab may be potentially dangerous for the baby with reduced bone marrow production of blood or immunoglobulin. But if we save disability in the mother, the baby can recover from this transient anemia, transient lower immunoglobulin, and both will be better off long term. So what about estrogen treatment? If pregnancy and the estrogen drop is causing relapses, and pregnancy in itself is a protective factor, why are we not giving estrogen to everybody? Well, I'm still not sure why not. So we know in animal models there's a positive effect. We know it does down-regulate TNF-alpha, which is if we give an TNF alpha agonist, we get disease activity, and it upregulates regulatory T cells. So we have a lot of reasons why estrogen should be good in the immune sense for patients. So there were tiny studies, and I haven't really found the results of larger studies that were promised. The design was published, but the results weren't. So there are only 6 small studies, 6 RRMS and 6 secondary progressive patients. Mean age was 44. So there was clearly an improvement in relapsing, but not in secondary progressive MS. But that's only 6. So we know the estrogen has something to do with the relapse. And you remember one of my earlier slides, how much more relapses there are in females than there are in males. So coming to the later stage of the female life, the menopause. So we all thought, you know, if estrogen and cycle has so much effect on your disease activity, you should have no relapses anymore after menopause. And that doesn't seem to be the case. So there has been a study on hormone replacement therapy, and I mean, it does also in healthy people, women, it improves your cognitive function, and in MS, it does improve your physical functioning. But I don't know if that is an effect on disease activity or rather an overall feeling better with estrogen replacement than without. So coming to an end, there's more and more young women that are being diagnosed with MS. You definitely need to include family planning when you make a decision about your treatment, because if you go on a treatment like fingolimod with rebound phenomenon, that will have an effect. MS does not seem to affect fertility or your pregnancy outcome, but you might not fall pregnant as quickly as you think. And pregnancy itself has a very positive effect on the long-term outcome of MS. And stable disease is paramount before you plan your pregnancy. And some of the DMTs are quite safe to be given throughout. Some are safe to be started with and then stopped later. So definitely think carefully about your pregnancy and discuss it with your specialist. Thank you for listening.
Jeannette, thank you so much. A lot of information in there. I have got a few questions, if you don't mind staying on to answer a few of those questions. First one is from Sophia, and it relates to menopause. And she said, should I expect a double dose of fatigue? I already have extreme fatigue. I'm 48. I'm perimenopausal. Is it likely I'm going to get extra tired, forgetful, and achy?
Well, that all seems like you should be on hormone replacement therapy. There's also natural remedies for estrogen replacement. It's better for your bones. And the only problem of not being long-term on HRT is our increased risk of breast cancer. So we usually recommend now not to be longer than 5 years on HRT.
Thanks, Jeannette. And I guess also pointing people to the Jean Hales website, because that is their main focus, is about managing menopause, and there's some great information there. So you can have a look at their website too. And Regine has asked, so the questions are all over the place and not in any particular order, Jeannette. So, are babies born after the mother has been on natalizumab? Excuse my poor pronunciation. So, are babies born after the mother being on natalizumab born immune suppressed?
So say that again. So when was the natalizumab given?
So the mother has been on that treatment during her pregnancy. Will her baby be born with immune suppression?
So what is seen in, so 5 out of 30 pregnancies had anemia. So this is what has been described with natalizumab, but the majority of pregnancies are doing fine and the fetus has no problem whatsoever. And the anemia that has been described, or thrombocytopenia, is something that is also transient. Yeah. It doesn't have to continue.
Great, thank you. And Kate's asking, what treatments are safe when breastfeeding?
So natalizumab is something that we would recommend to start fairly early. There is a small amount that has been shown in the breast milk. Safe are beta interferon and glatiramer acetate. So even if there is a small amount also in the breast milk, as you know, everybody would happily swallow the tablet, but the treatment is broken down, and so it's not effective. But it comes in contact with gastric juices. The injectables are definitely safe. More and more people recommend to start a natalizumab because the risk of relapse, not having it, it's higher than any risk to the baby when you breastfeed. It's negligible. So I can't say it's safe because there is in the breast milk, but it's negligible. We have found that DMF, which is a category B, so that's dimethyl fumarate, if you breastfeed with that treatment, unfortunately, that causes upset tummy in the baby. So that might not be the best option. It might not be dangerous, but it causes them to get quite upset tummy.
Thank you, Jeannette. And Kim is asking, what about the combined contraceptive pill? Is there any evidence, given the estrogen in that, is there any evidence that this reduces MS progression?
Yeah, that was postulated, but not found to be the case, as far as I recall. So that we can't say that contraceptive therapy is protective for MS.
And same question, different contraceptive device here. So Liz is asking, if you have a Mirena IUD, does this provide any protective effect?
Some of these release some progesterone, but I don't think that has an effect on MS.
And just to clarify then, Haley's saying or asking, is Ocrevus safe for breastfeeding?
I think the jury is still out on that one. There is a recommendation at the moment that you should discard your after your infusion, you should discard the breast milk, as it isn't an ongoing therapy. It might be safe to do that.
Okay. Super, thank you, Jeannette. That is all the questions that we have here today. So thank you so much for your time and expertise, really appreciate that. I'm just going to take the screen back here and just finish off with some housekeeping.
Thank you for all the interest, and thank you for all the interesting questions.
Yeah, thanks, Jeannette. I can see people have been really attentive and certainly quite challenged by some of your poll questions. So just a reminder to everybody, any questions and support you need, you can call our Gateway MS Connect on 1-800-042-138, or you can email them. And lots of good reasons to give MS Connect a call, advice on managing symptoms, referrals, our peer support, our education programs, our employment support, respite options. You can get through to nurse advisors, to social work advisors, and to MS experts. We do provide, as mentioned, peer support. We do phone support, face-to-face groups, not at the moment. They're temporarily converted into telegroups, but we run a range of telegroups for people, and we run Facebook groups, etc. And peer support seems to be extremely important at the moment in this COVID situation. We've got a Get Your Act Together tool for people to get some symptom management online, some symptom management advice. And we have employment support services across Australia to help you find work, succeed in work, and stay in work, which is really important. We are an NDIS provider, providing different services in different locations. Some information here about My Aged Care, if that's relevant to you, if you're over 65 years of age, and there's a webinar recording on that too. And we have a great range of podcasts, of which Jeannette contributed to one recently for newly diagnosed people, and you can get those downloaded from your podcast provider, from Spotify, from Google Play, etc., from Apple Play, or from our website. So thank you again for your time. Lovely to see so many people on board, and thanks again, Jeannette, for your time today. Bye for now, everybody.